As and right there, it's not our AI chatbot, but it's actually our candidate for Illinois 7th Congressional District, and Kina Collins. So, Kina, take it away.
Thank you so much, John. John's been such a great help on the campaign, and I just want to thank everybody for being here tonight for a very important conversation. And really, I want y'all to view this as a back and forth conversation with us, not just like some stale presentation that's giving. It's good to get the data points from people directly and answer your questions directly. So I'm Kina Collins for the folks who may not know me, who may be on the call and new to the bunch. And I'm a resident of the West Side of Chicago. And the first brush that I had with understanding the disparities in Illinois 7 was growing up in the Austin community and witnessing a young person gunned down in my neighborhood. And I knew the victim and I knew the shooter, and it changed the entire trajectory of my life. I knew that the bullet was flying in the air long before anybody pulled the trigger because we did not have proper grocery stores. The bullet was flying when our schools were shut down. The bullet was flying when there was lead in the water, toxins in the air, and our community looked vastly different than a 10-minute ride west into our neighbors over at Oak Park. And so I began to get trained in violence prevention work, and I started to see violence in itself in neighborhoods like South Austin as a public health crisis and epidemic. And so I was very fortunate in my time as I stepped into my early career to serve as a national organizer with Physicians for a National Health Program, which is a national nonprofit of 20. And my whole job was basically to train 20,000 doctors and medical students across the country to advocate for single payer Medicare for all, for universal health care in our country. Because the United States is the only developed country in the world without a universal healthcare system. And I know I grew up obviously listening to people talk about education being the great equalizer, but really great access to primary care is the great equalizer in our community. It's the difference between whether people have 10 to 30 more years to live, depending on your zip code in the Illinois 7th Congressional District. So this has been my complete life's work. And I have dedicated myself in making the commitment that one, obviously, we want to push back on the GOP and try to protect the ACA because that is the current healthcare system that we are under. But that's just the floor. That shouldn't be the ceiling, right? We can expand to universal healthcare in this country where people have access to dental, to vision, to hearing aids in our country, that we don't have to divide between the undocumented and the documented person here in the United States of America, that everybody could have quality health care, build strong local economies through building healthy communities. And so I'm very passionate about that. And my time at PNHP was the reason that I decided to run against Congressman Davis 6 years ago, because I found out that he was actually taking some of the most corporate PAC money from pharmaceutical and private insurance companies. And I asked him to return that money. And he told me no. And I said, okay, I'm going to run against you. Illinois 7 has a 30-year life gap, a death gap between downtown Chicago and West Englewood. Between the Loop and the west side of Chicago, it's a 14-year life gap. We have some of the largest death gaps in America, which means that your life could be determined how long you live and how extended you live and how much of a quality of how your life is determined and based off of a 15-minute to a 30-minute car ride. And that to me is unacceptable. And so I wanted to run a campaign or we did run a campaign all the way back in 2020 that refuses corporate PAC money, that we could have a representative that can speak with a moral authority and clarity on the issues to fight for things like healthcare. Because to me, it's not just a privilege, it is a human right. And so with that, Been very fortunate to surround myself around folks who are a lot smarter than me when it comes to healthcare policies, frontline folks, physicians, pharmacists, um, uh, people who know the healthcare system and have dealt with it intimately to educate myself. And that's exactly what I'm going to do once I'm elected this year in the election. And so I'm very happy to have a very special guest, somebody who I respect very deeply and who has worked in our actual district. Um, Shahab, I don't know what you want to go by, Dr. Udin.
Yes. Yeah.
What do you want to go by? But
I
I
guess
would love
Dr.
to
Shahab, but yeah.
I would love
Um,
to toss it to you so that you could do an introduction as well and we can get into the conversation.
okay. Yes. My name is Dr. Shahab. I'm an internal medicine physician. I actually did my training in Oak Park at West Suburban Hospital. It's kind of what drew me to this conversation and also just learning more about all the candidates and what's kind of going on here. I'm an internal medicine physician. I've also been a chief medical officer in Ascension Healthcare. So I've gotten a chance to see healthcare from different angles as a doctor on the front lines as well as an administrator trying to keep hospitals open. And so Kina kind of hit the nail on the head. You know, we're seeing so many of these disparities, and it's not happenstance that geographically where you are kind of determines if you're going to live or die in certain circumstances, you know. And with the more and more pressure being put onto the system by taking away ACA subsidies, by not providing hospitals to be quote unquote profitable, you see areas where, you know, a heavier Medicaid population or where healthcare is not affordable, having less resources to be available to them. So let me just give you a personal example, right? So the number one reason for bankruptcy in the United States is medical debt, right? So sometimes I will have my own problems, and people are like, you should get that checked out. You should get some blood work. You should get this. I'm like, I don't want to get that stupid bill if it's just, you know, something I can just, you know, figure out later because I just don't want another bill coming in the mail. So it's not like the physicians or nurses within the healthcare system are getting some sort of break from this chaotic chaos that's going on. So one personal example is like my sister, for instance. I've known her since she was a kid. She used to always scratch her head like nonstop. I was like, you have obsessive compulsive. You need to take some psych meds. Um, Long story short, she got married. She moved to Canada. And like, I just thought she was a neurotic person who always scratched her head. When she went there, she finally actually got to see a dermatologist, right? Ended up, she had this very rare form of psoriatic eczematitis of the scalp, right?
Mm.
And they put her on an injectable medication that she took for 3 weeks, and now she no longer has it. So we live in the most developed modern country, and just going across the border, she wasn't scared to see the doctor. She wasn't hit with multiple layers of things. Yes, no system's perfect. She had to wait, but we had an answer for someone who was 35 years old, who had this chronic condition that was never been able to be taken care of. So this is not about like just people who are maybe on one side of the financial spectrum. It applies to everyone. So those are real consequences. And what we're seeing now, especially in the hospital, even when people have insurance, right? It's like technically insurance, but the deductible is so high, the copay is so high. A lot of people are going to say, you know, do I really need to? Like, it's the same decision I make. Is my arm pain just going to go away? Do I really need to do anything? So when that starts happening, it ends up where the ER becomes your primary care hub. Pretty much at that point, you have not been able to get your routine medications. You're not able to see your physician on a routine basis. So when that starts happening, the ER starts to become your go-to place. Now, the second scenario we're seeing a lot of is that some people, I mean, if you're looking at your premiums for anyone who's self-employed or is not getting their insurance through their premium, their workplace, the premiums are very high. and they're only going to go up for a multitude of reasons. One, they're cutting some of the subsidies, which was making healthcare affordable, quote unquote, Affordable Care Act. So when those subsidies go away, the price goes up. So now, what role does like insurance play in all this? Sometimes there are those healthcare companies on the insurance side that are paying some of these politicians or other vehicles that have power to continue the status quo, to line their pockets. And so now we're seeing people who are just falling out of coverage. They're like, I'm just not going to have coverage. So what does that happen to a broad group of people? A good majority of my patients who are in the hospital have something that could have been prevented. And it's hard for me to put a percentage on it, but just having a routine checkup would have met their needs. But because they couldn't get even to their primary care doctor, they're ending up using the ER. When there is this high utilization of the ER as a primary care doctor almost, that ends up creating higher healthcare costs, but ultimately leads to some places people are like, you know what? This area should not have a hospital because it's not profitable. That's what they're going to start thinking. And so just one other statistic I want to bring up is that, you look at the maternal mortality in the African American community. One of them is getting to a hospital in a timely fashion. And I've actually witnessed a medical emergency with my own wife where we were at the hospital. She was having some bleeding. We thought she was going into labor. She went to her OB-GYN doc. She's like, no, you're not. It's just a little bit of spotting. Go home. I go back to work. About 10 minutes later, my wife calls me, blood gushing all over the floor, all over the floor. She had a placental abruption, which is a life-threatening situation. I drove 100 miles an hour back home, put her in my car, and I drove 100 miles back to the hospital. And she got there. She had the baby. The baby was healthy. Thank God. But looking back to all of this, had I hit traffic, had I not lived close to a hospital, maternal mortality is really, really incumbent on having a hospital nearby. Because we were able to get into the ER, get to the OR, operating room, within about 15 minutes, she was able to survive. So now if you're in a place where they're saying, well, there's no profit margin on that, nobody has insurance in this area, we're going to close it down. What do you think happens in those circumstances? People suffer complications and even worse, death. So it's all a trickle down effect that we are seeing. And that's one aspect of it. I can go into other aspects such as like prescription drugs, like even if you see the doctor, then it's like another wild goose chase when you go to
So I would love to get into that with you,
Yeah.
Shahaab, because we are going to open the floor for any questions that folks have, and they can also drop it in the chat. But you just hit on something that is impacting Illinois 7 heavily, and that we all need to be paying attention to in the district: safety net providers and healthcare and hospitals in our district. We are seeing West Suburban, the story of West Suburban, and it's getting ready to be shut down. I mean, parts of Loretto Hospital have been shut down. This was a huge fight on the south side of Chicago years ago that there was not a trauma unit, even though at the University of Chicago for adults, even though there were several victims of gun violence, for example. How important, are these safety net hospitals? And from your perspective as a physician, I mean, I want to share with the group too ideas about what I think we need to do in the Illinois 7, but how critical is it that we fund and we defend? Because I think you said something very important. You said, well, they base it off of if people have insurance or not, and it's like a business model. But we know that when these places are shut down, that this is not a business failure. This is a policy choice being made to shut these safety net hospitals down. So, I mean, I would love to hear your perspective as a physician on the importance of that and ways that you think that needs to be protected and defended.
Yeah, I mean, it's very tragic. You see it in like a lot of pockets of Chicago, and it's becoming more and more brazen. Like, I think there was a time where people would say per thousand people, we need this many beds in a hospital nearby to service them. There was like some sort of equation. That's kind of gone out the window now with so much kind of corporate influence, and also like the lack of governmental and state support at certain places, like the old Mercy Hospital or Weiss Hospital that used to be there, and the other ones that were uh, and the other hospitals like in the west side, like West Sub, in those areas. So not creating opportunities for people to have insurance that is affordable, that at least keeps them with some coverage, and it's kind of pushing people out. The way the premiums are going and the way that the state funded programs are going, it's going to continue to get worse unless there is a policy change. And I'm not a policy expert, unfortunately, because I don't know how that would be fixed. I would ask you, but being in the hospital, seeing it day in, day out, it's frustrating, because the goal of as a provider is to help people get better. When you see them coming back and forth from the hospital to home because they couldn't get the prescriptions or they couldn't have a follow-up appointment, you're just putting a band-aid on a bigger problem.
Thank you so much. And then I'm sorry, did somebody else, I don't know if somebody came off mute. So one of the ways I think that you mentioned, which is absolutely true, we are in a gridlock right now with the Trump administration, and they are cutting and slashing Medicaid, Medicare, which is definitely impacting a lot of the safety net hospitals in our area. So we do have to lean on and organize, in my opinion, on the state level and push for that federal funding on the state level for our safety net hospitals. One of the things that we've proposed in this campaign and even in previous election cycles, because I think that there's such a case to be made in the Illinois 7 based off of the death gaps that exist by regions in this district, is that in the first 100 days, we want to put together a healthcare and life expectancy task force where organizers, environmentalists, physicians, activists, people come together and we basically pinpoint and target how do we start chipping away at this 30-year life gap. And it does start with funding, but I also think it starts with community relationships and that organizing piece. I do want to pause here before we move forward to see if anybody has any questions so far. If you want to come off mute, you can, or if you want to put them in the chat, you could also do that. Um, I don't know if I see anybody coming off. We're good. Nicole, are you getting anything in the chat?
The chat is disabled.
Oh, yeah. Nicole, the chat is disabled. Sorry. Thank you. Um, And so with that, a lot of people have asked why, should folks support Medicare for all, right? Where we talk about the elimination of copays, premiums, deductibles, and to answer to your early point earlier, Shahab, premiums have went up on average to about $1,000 per person in the United States of America. We actually have a supporter of ours who came to me and basically explained that she had to cancel her health insurance because she cannot afford it. She, at the end of last year, she ended up going to her primary care physician and doing her physical and letting her primary care physician know that she wouldn't be seeing them for a while. And the primary care physician asked why, and it was because she was no longer going to have health insurance. And her request was that she got all of her panels done, and if the physician would be willing to give her her prescription drugs for up to a year. And the physician was limited to only giving her about 5 months of prescriptions. And so that for me weighed really heavily on the sense of urgency about a very basic necessity in getting access to healthcare. one of the things that comes up is like the cost that is absorbed in our healthcare system, which is around administrative cost. Can you, as a physician, talk to us a little bit about that? Because I think that progressives get, hit a lot about, well, you have these grandiose ideas, but how are you going to pay for it? And we know that there are studies that show that a lot of the time is being spent and money is being spent on overhead. So can I just pass it over to you to say a word or two about that?
Yeah, I will definitely get on that one point. Just one more thing to say about this universal health care, Medicare for all. It's like there's another issue that also comes up with it. A lot of people can't make life decisions or career choices because of health insurance. Like if you wanted to start your own practice or your own business or do something that you found exhilarating, take a chance on something else, you have to make the chance, you have to take the chance on like, should I stay in this dead end job or like whatever situation I'm in? Or lose my health insurance, which means I could get hit with a medical bill and then create, go into financial ruin. So to your point about the overhead in terms of healthcare, is that what contributes to the cost of healthcare? If you look at the overall money spent on healthcare in the United States, it's the highest out of like if you take like Western European nations, Canada, all of these countries that have in their healthcare system, and you compare them with the U.S. spends the most, yet we have the worst outcomes. And some of those places have socialized healthcare, some of them have universal healthcare or Medicare for all. Canada has a socialized system. Europe also has something similar. But despite the number of how much money we are putting into the system, it's actually not benefiting our healthcare outcomes. I put that there to say that there is a way to pay for this that is economically viable, right? When people do not have coverage, they end up in the ER, which incurs way more expenses on the healthcare system. So if you can see somebody in the clinic get a prescription for something and you don't need to go to the ER to deal with that situation, that's going to help the overall system be able to sustain itself. So that's one big thing. The biggest healthcare costs are emergencies that come up in being admitted to the hospital. So having access to care would decrease that one big expense that comes up.
Yes, that's a really great point. And we'll make one more point, and then Leslie, I see you on Stack. Um, One of the big issues too for these safety net hospitals and providers is that they're losing doctors and nurses. And this was something that really came up in PNHP as I sat with medical students and even residents, was that they really didn't want to take up primary care because it didn't pay enough and they were absorbing a huge amount of student loan debt. So this issue is not just isolated to the healthcare industry. One of the things that I really want to work on in Congress is that we shield our healthcare providers from this medical debt so that we open up the possibility for them to go in and want to be primary care physicians in places where we really need them. And so we trade that medical school debt in for their services to these communities. But that came up a lot. I mean, is that something that you hear often as a physician, or are there other things that you believe is kind of siphoning the ability for doctors and nurses to stay in these areas that really need medical deserts, really?
Yeah, I think that's one huge part of the stress that comes along with being a healthcare provider, being a physician, especially. Like when I finished my residency, so you're not earning until you're about 30 years old. Then when you get out, they immediately, the bank's like, here, this is what you owe us. And for me, it was like 450,000.
Wow.
So at that point, you want to serve the community, and there was communities I felt like I would be better utilized, but at the same time, the opportunities are not there. So that medical debt can be crushing. I mean, it affects the rest of your career essentially because you end up making decisions just trying to find something where you can actually get out of that debt, and then maybe one day think about buying a house. But if you have that stack of medical debt in front of you, you don't even think about those things.
Thank you. Thank you so much for that. Leslie, we see you are on Stack. Thank you for being patient. I think you have to request she unmutes, Nicole. Leslie, oh, there you go.
That's it. Okay, I actually have three. One is, what are we going to do about Sundays? Because I always get sick on a weekend or a holiday. And the only place that if it's not a telephone thing, or if it's a really, something a little more complicated, I end up having to go to the emergency room, which is not a good thing. Two, when my adult daughter came home several years ago, and she didn't have health insurance because she wasn't working, and we were going to have her on Medicaid, but I was afraid that there weren't enough doctors around who accepted it, and that they may give her less respected treatment if she was on Medicaid rather than any other kind of insurance. So we put it on ACA. And at that time, it was over $400. It was like $450 a month. Plus, there was a $5,000 deductible, and it was so ridiculous. After a while, we put her. She got onto Medicaid, so she's on Medicaid right now. But the other thing is, I remember Bernie had submitted or talked about Medicaid for all, and it wasn't. He talked about how it was, or the bill itself included how they would gradually get everybody on it, like lowering the age, maybe a decade each year or something, and then also giving a 2-year thing for, every insurance. I mean, that any doctor's office has to have a staff that deals with all these insurances. Well, they won't need that person anymore when everybody's on Medicaid for all, supposedly. And so they need to have 2 years to find another job. And then there's a shortage of doctors and nurses. And so they also had in there something about helping with financing the education to get more people to become down to medical professionals. And I forgot what else was in there, but there's a lot of things that it just doesn't happen right away. And does that mean that doctors become government employees, or are they still entrepreneurs? How does that work? I don't expect you to have
So
the
let me
it's just a question.
Yeah, let me answer the first question, because your first question is an important one, Leslie, about Sundays. In a district, it's actually, Leslie, you're probably the first person that asked me about that, but it is a common issue in Illinois 7, particularly on the west side and south side, because when you're a single parent and you're working 2 jobs, you may only have the weekend or, to go to your clinic, and then it's closed, right? There is a federal program. So 2 things on that. There's a federal program called HRSA, which are I'm going to get it right, Health Resources and Service Administration. And there's that programming is specifically for federally qualified health care centers in our community. And there are expanded hour grants that subsidize or give that money to those healthcare clinics that expand their hours. Now, here's the problem. We would have to apply for that and really push that funding to be expanded in the Illinois 7, which we're going to need once West Suburban goes down and if we continue on this trajectory. But the second piece is exactly what Shahaab and I just touched on, which was we actually need more nurses and doctors. So when you bring up the point, I got to harp on this and keep saying it. When we bring up the point that we have to eliminate student loan debt so that people feel that they can step into those type of pathways in their career, that will basically free up our workforce and help us expand the workforce. So that's why we're advocating for those things. And then they have something called the weekend bumps. Leslie, which gives like reimbursement rates for people who do operate 7 day a week institutions. So there is federal funding that goes to these clinics or can go to these clinics. We have to fight for them, Leslie, and we have to make sure that we're, making sure that we're fighting for those things to be in the federal budget. Shahab, I don't know if you want to jump in on any of the questions that Leslie asked.
Man, I feel like Leslie knew more about the healthcare system than me. She knows what she's talking about. She needs to be a part of that task force. But yeah, I mean, there's a lot of red tape, and one thing with like a governmental system is like there will be less of these prior auths and uh, kind of barriers to getting things. One time I filled out a form for a patient to get a wheelchair. Okay.
Mm.
When patient got the wheelchair, but they got it without wheels.
Oh,
I got another form for wheels. So then I had my nurse, I was like, please call her, tell her, ask her if she got wheels. She's like, no, I just got here, it doesn't have wheels. So these types of gimmicky things that like are just unethical, really. It takes some of those players out of this space where they bombard providers with so much paperwork or so much red tape, so much prior authorization, where by the time the goal is to delay till the person doesn't need it or doesn't, something happens to them and they don't have to pay for it, right? But with this single payer system or Medicare for all, you have like kind of one kind of gateway. There'll be a standard of how to get these products that you need for home for elderly people. If it's a wheelchair, if it's DME, if it's a bed at home, those types of barriers would go away. And and a lot of to your other question about would you work for the government, most of the bills would go to one payer. So thus getting rid of in-network, out-of-network, PPO, HMO, like all of these crazy letters we've kind of become accustomed to, which makes it like its own kind of it's very tough to find people within network, but that would get rid of those types of issues.
Right. So doctors in themselves would work for themselves or their private practices or their hospitals. The only change really would be that it would be one single payer paying for all the bills without this fight of having to choose between which private insurer that you send money to. So it's really an administrative fight, really that's happening. So I
and
don't know. Oh, go ahead. I'm sorry, Leslie. I think I hear you.
I'm sorry. I didn't mean to interrupt you. I did have another issue that I wanted to bring up.
Mhm.
We unfortunately we're on Medicare C, the Advantage for Medicare. And while I do get all the kind of stuff, that's nice that Medicare doesn't provide, the eyes, ears, and whatever, and teeth. Um, but I have one prescription, and I learned that CVS owns Aetna. So they self-pollinating, I guess you'd call it. It's more profitable. And with the one that I have from Humana, they're connected with I can't remember the name offhand, but they've got another Centerwell pharmacy. And you can get like 90 days of a prescription that you know that you're gonna have forever. And but they send it like I haven't opened up my next bottle and they're already sending me the next one. And I'm
Mm,
thinking they're busy collecting money from Medicare.
mm.
The more prescriptions they get, the more they can claim things from Medicare. That's
Hmm.
that's what I'm wondering about and how that works.
Do you have any thoughts, Shahab, as
I
a
don't,
physician?
yeah, I don't know much about that, but I do know that some of these Medicare Advantage plans have been not good faith actors.
Yep.
There's
Yeah.
a lot of gatekeeping, and so this is outside of anybody's. This is my personal view. When I see patients that are trying to get to like a nursing home or need some home health or something else, when they have one of those advantage plans, I call them the disadvantage plans
There you go.
because you are at a disadvantage. I mean, Medicare is not perfect, but I do know that like if somebody requires skilled therapy at a nursing home, that they will approve it. But if they have like Humana or Aetna or all these other plans, they'll deny it. Then they'll do a peer-to-peer with me, and they'll try to get like a 15-minute window. And I'm like going to the bathroom, and they said they tried to reach me, and then I have to call them back, wait on hold for 25 minutes, and then it doesn't happen. So there is some legislation that's been brought up to Congress about the bad faith acting in this Medicare Part C or Medicare Advantage plan. So, yeah, that has become a more important issue lately.
Yeah,
I get monthly summaries, and recently I've noticed that there's been declines of claims.
it is the what y'all are referring to is the AI generated denials, and it's actually coming up in flagged, and people are calling for way more federal regulation around that, Leslie, because people are experiencing these denials at a higher rate. But I mean, it just goes without saying that Medicare Advantage, I think it's a scam. You know, they call it an advantage,
Right.
but the only ones who like benefit off that are these insurance companies that get millions of dollars while our seniors get skinnier benefits and they don't get what they need in the process. And so we do need to send, and I think you've harped on this in the community before, Leslie, and you still do. We have to end Citizens United because a lot of the reason why this has been pushed forward is because lobbyists have done a bang up job of lobbying to keep this scam going, essentially. So we have to get people in to speak with a moral clarity on it, but that is not your imagination. More and more people are reporting that, and more companies are using AI algorithms to auto generate these denial letters to folks, and people have been calling for federal regulations around it.
I did get to see my doctor. It's afterwards I get a summary of the past month, well, of all the visits or phone calls or whatever, and it says that it was denied to the um to the service giver.
Yep.
So so it's hitting the doctors, not me, but it's hitting the doctors.
Yep. Yep. John, I see you on the stack.
Yeah, so I have a ACA plan, and the subsidies on my plan have obviously lapsed. So I went from paying about $57 a month to about 200. So yeah, it sucks. But and I've heard now, Trump, talking about like what I assume is going to be more like a health care savings account for most Americans. Um, could you two either like speak to what that would look like, or why you think that would be not a great idea as opposed to a Medicare for all system?
Did you want to touch on that, Shahab? I know you talked about ACA subsidies.
Go ahead, Kina. That's all you.
Yeah, I mean, I think that this is actually there's been a little bit of movement, John, on this. I don't know if you've seen recently, but Lauren Underwood fought for amendments to try to stabilize the ACA subsidies. I think ultimately moving to a Medicare for all plan, it eliminates those copays, premiums, and deductibles. So it's an overall just cheaper plan. So that's why, in my opinion, it's better than whatever Trump is offering, which he says is like a concept of a plan because it streamlines everything. I don't know if that's like answering your question, John, though.
Yeah, I mean, I've seen like I guess similar programs of like a healthcare savings account be offered as an option when shopping in the marketplace. I just like curious if you all have had experience dealing with those, and what kind of your take is on like a essentially a healthcare savings account.
I mean, HSA will save you some money, but it doesn't solve the problem of, to me, my political praxis about it and the advocacy for it is that it's the wasting money that we're wasting in the current system. And as the premiums and everything continue to go up, the people are getting less for their money. ultimately. So if you're saying like, why would that be a better option, is because currently where you're getting what you're seeing now, which is an increase in your ACA subsidy. It's going to continue to increase. I don't think that there's an actual active plan put forth on how we cap that and how we move forward on that. And I don't know on the physician side, like how that falls in what you're seeing with your patients, Dr. Shahab. But for me, I think like we're bleeding out money currently in our system and people are getting less care. So I'm not like a huge proponent of it.
Yeah, I mean, I haven't heard too much about the HSA accounts for many people, but to what John was saying, they have um, the premiums have bumped for a lot of people's insurances. That's what we've seen.
So, I mean, John, do you obviously outside of, I mean, I think this is interesting because for people on the call who don't know, John is also a veteran. Like, have you seen in that world how that has impacted people in the veteran world?
So some people, go through the VA for their health care. Personally, I don't, a number of different reasons, but in any case, um, you know, the VA had gotten better, especially prior to, I think, right prior to COVID with the PAC Act, because I think it influx there was an influx of cash that went into the VA to basically start hiring more personnel to lower wait times, because literally like veterans were dying waiting for care at the VA. I had previously gotten like prescription medication through the VA, and it had gotten service through them before. Then I got employed, and so I was using my employer's health care, and now I'm in a position where I don't have employer health care, but I'm going through the marketplace essentially. So the VA had gotten better, but I think, with this administration cutting a lot of jobs at the VA, it really also now we're kind of in a similar position, I think, where we were prior to COVID, where more veterans and are going to be waiting for a care, and especially those who have these like long-term debilitating effects that are just now starting to come to the surface, like people who are stationed at Camp Lejeune, North Carolina, where I was stationed, who were exposed to contaminated drinking water. They're going to be dealing with these health effects right alongside currently the Vietnam veterans who are going in there and getting treated for Agent Orange exposure. So, it's just like this cascading effect that keeps coming, and I don't see it really getting any better.
Well, the issue too, though, John, because a lot of the Senate is pushing for these HSA accounts. It only works. It's giving you like a few $100s, and like a tax sheltered account, but instead of lowering your monthly premium, so they're trying to replace that for lowering your monthly premium. But that only works like if you have extra money to put into that account. Like our goal should be that like we're lowering these premiums for people and we're giving them access to healthcare and not giving them like a middle of the road watered down version of what they can do. So to me the HSAs are not like really helpful. It's not solving the problem. People saw their premiums skyrocket. Some people saw like it upwards to $800 to $1,000. And so, you know, now that we're in the end of January, millions of people have dropped their health insurance because they just cannot afford it. Um, and so I do think that it is going to be a struggle. I mean, on top of Medicaid being cut, this is going to be a battle that we really have to collaborate with on the state to expand the funding for people to get access to healthcare because a lot of folks are dropping. But my stance on it is that the HSAs are not like a better option, in my opinion. Um, I'm sorry. I see other people. I see Marianne Bucks at the west side of Austin is a food apartheid. The community members in Austin have to come into Oak Park to get fresh foods and vegetables. There are so many lots that could be used for growing vegetables to keep them healthy. This is one way to get to the root of health disparity. Yeah, access to fresh food and folks have heard us say this constantly on the trail that in a neighborhood like Austin, it's easier to get a handgun than it is to get fresh produce in certain areas. And that is a travesty. And I think that us serving as a food desert in Austin needs to be a top priority for whoever ends up getting this seat for a multitude of reasons. And it goes into not only just like the maternal mortality that was being talked about, but infant mortality, right? Like having the nutrients and things that you need. So it's a big contributor to the 30-year life gap that exists in Illinois 7. Terry says we have moved from nonprofit hospitals to a series of for-profit hospital management to bleed our hospitals dry. Yes. Shahab, did you want to say anything?
Pretty much, yeah. It's just like a trickle down effect, from top to bottom. Like, and even if you want to look at it on a macro level, like, some of the game is that some of these healthcare insurance companies, they enroll a certain amount of patients, right? So then they take that pool of patients and they'll go and negotiate with another hospital. Well, this is how much we're going to pay you for this person being here for 3 days, right? So the hospital and these insurance companies kind of try to negotiate, like, hey, we want this is how much we should get paid for this service for 3 days. The insurance company can say, well, we have this pool of patients, so if we say you're out of network, these patients aren't going to come there. And so they're like, wait, hold up, let's talk. So it's this back and forth that's kind of keeping things very tough, even for hospitals, even with like a good payer population, to get the services and the reimbursement that they deserve sometimes, because the insurance companies have so much power.
Yep. We probably have time for like one or two more questions. It is 8:22. Just giving a time check. I know we started at 7:30. Did anybody have any last questions for Dr. Shahab or I? What is your response? John says, what is your response to people who claim that undocumented migrants receiving treatment are the reason for healthcare costs going up? Dr. Shahab, did you want to say anything or did you want me to take that?
Go ahead, you can take that one.
Actually, undocumented peoples actually subsidize our healthcare system. They pay billions of dollars into our healthcare system and they are not able to use it properly. We are seeing an uptick of undocumented peoples actually completely skipping the ER altogether now as well, because they are afraid that they are going to be visited by ICE. We are seeing an upliftment of regulations that once prevented, they used to be called safe zones, that once prevented hospitals from being raided by like entities like ICE from coming in. And so that is a myth. That's actually one of the myths. Migrants and undocumented people actually pay a ton in taxes into our healthcare system, and they don't even get to use it. So it is a benefit to the United States of America, and it is an absolute privilege that they are even subsidizing our healthcare system, and we should change that. Single payer Medicare for all leads to a healthcare system where the model is very clear, John. Everybody in, nobody out. That means that everybody gets to participate in our healthcare system, regardless of their legal status as a citizen. And so that is a huge myth that the GOP and other people who are anti-immigrant like to espouse, but the numbers do not shake out, and that is untrue. Dr. Shahab, did you have anything?
Yeah, I mean, even if you look at rural communities where there's not a lot of undocumented people, they're running into financial crises. Like I'm from uh, Timbuktu, nowhere, Indiana, and out of 4 hospitals, only 2 are standing. There's no undocumented people there, really. It's just the community. So there's a systemic problem that's going on that is probably the root of this. So I couldn't attribute that to the healthcare costs going up.
Well, I mean, outside of that, I think a really big issue that we have in the healthcare system, and when we say we want a single payer system or we want Medicare for all, that means fully culturally competent healthcare. One of the big issues that we have in our healthcare system when we talk about Black women dying while giving birth, when we speak about myths that constantly get put out about undocumented people's using up our healthcare, is that we are building a culturally competent healthcare, universal healthcare system in our country. And that is something, John, that I want to work really hard on as a representative, is that we put those restrictions back in place that create hospitals and schools and churches and places of worship as safety zones, not for policing and ICE raids to be taking place when people are literally trying to either fight for their life or get proper care. They should be able to come to the hospital unafraid and get proper care and unafraid that they will be deported or arrested in some capacity. And so thank you for lifting that up because that is a really big issue. Um, Leslie, yes. Leslie says women need to be included in medical research studies. Our bodies react differently than men. We actually had the Illinois 7 healthcare town hall, and I was the only woman candidate up there. And one of the things that I highlighted outside of we get treated very differently in the healthcare environment, Leslie. Right now, currently, as it stands, we have less rights than our male counterparts. In some states, it's easier to obtain and get a prescription for Viagra than it is to get a Plan B in our country. And I think that that is absolutely ludicrous and absurd. And this kind of springs off something that we didn't get to touch on, but it is something that I'm also very passionate about. I know that we talked a little bit tonight about shielding incoming residents and physicians by eliminating student loan debt, and they're not being crushed in student loan debt. One of the other things, because we are in very peculiar times under this administration that we have to shield our physician and healthcare providers from, is criminal indictments for doing their jobs, right? There has to be legislation put forth that says that we will not criminally persecute physicians for executing abortion or performing abortions or performing medical procedures that could be life-saving for patients. And we have completely blurred the lines and the boundaries of that. And so thank you, Leslie, because that makes me think of that every single candidate in this race needs to be making the commitment to protect our healthcare workers when they're blatantly under attack. Shahab, I don't know if there's anything that you want to say on that, or if you have any thoughts about the different legislation that's been pushed forth to criminalize healthcare providers, but that's something that's been at the top of my mind because we know that Illinois is a haven state when it comes to reproductive freedoms.
Yeah, thankfully, in my capacity as a internal medicine, I don't have to run into that, but I have heard from colleagues they're very shocked at the different laws in different states, such as Indiana versus Illinois versus Wisconsin, and being able to prescribe or carry out those procedures.
Yep. Well, we are coming up on time, y'all. I do want to thank everybody for showing up to our virtual town hall. We will be hosting more virtual town halls as healthcare is becoming the top. It has always been the top issue for voters, but even more now, as John and other people have pointed out, Their premiums are like skyrocketing at this point, and people are having to suspend their actual health insurance. This is becoming a life and death situation for prenatal, postnatal care, long-term care, our senior community, and everyone in between. I also just would like to lift up and hold space, if I could, for the transgender community and the importance that our campaign has taken the vow to lift up gender affirming care, and why that's going to be important. We're seeing that specifically being attacked. In our government, and we just really want to make it plain and make it clear that we're going to fight really hard to fund gender affirming care, and we are going to stand with the LGBTQ community on that. And so I know we didn't get to delve deeply into that tonight, but that was a lot of the work that I did with the Illinois Council on Women and Girls Act. It was to include the voices of non-binary and transgender people in that conversation, and people who birth that do not identify as women, right? And so when we talk about culturally competent healthcare, that's exactly, what we're talking about. So thank y'all so much. I do want to be respectful of everyone's time. And please, if you have any questions, feel free to reach out to the campaign. We'd be more than happy to answer that. Thank you all.
Take care.
Thank you. Bye.
Take care. Bye.
And you're
Okay. Did we stop?